Hospital for Sick Children in Toronto, Canada. Dr. Walsh finished her postgraduate training in Canada and received so many awards. Her CV is really long. And also many publications, and also involved in many society members. She has interests in the field of endoscopy, and also during the era of COVID-19. So she'll give us a talk on pediatric endoscopy in the era of COVID-19. Please, Catharine Walsh. She'll be give us a talk from the pre-recorded video. So if you have any questions, she will be with us live after the third session of this morning. Please, Dr. Walsh.
Thank you for the kind invitation to speak on pediatric endoscopy in the era of COVID-19. I'm extremely excited to be here today. I have no conflicts of interest to disclose. As you are all well aware, COVID-19, which is caused by severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, is a highly transmissible virus and is spread through human-to-human transmission via contact, droplet, and airborne routes. As the pandemic has progressed over the last 2 years, we've learned a lot about the virus, its pathogenesis, and its spread. As coronavirus is transmitted by aerosolized particles, it really places us as pediatric endoscopists at risk. Upper endoscopies and related procedures such as ERCP are considered to be aerosol-generating procedures, as you're often blowing air into the mouth and oral cavity, and patients can cough. Additionally, endotracheal intubation is an aerosolizing procedure, and we know that many pediatric patients are intubated during endoscopy. Furthermore, SARS-CoV-2 has been shown to be viable in aerosols for up to 3 hours. So all of these in combination really place us as risk as pediatric endoscopists. Another question is, where in the GI tract is COVID found, and what is the risk of fecal-oral transmission in the endoscopy unit? In a study of over 800 adult patients in Japan who were asymptomatic and tested for SARS-CoV-2 ahead of endoscopy, they found no positivity in saliva samples. However, there was some cases of positivity in gastric samples, as well as a few in intestinal samples. And this study really highlights that the virus may be present in GI fluids even when no detectable virus in an individual's saliva. Because COVID is transmitted via contact, droplet, and aerosols, we know that transmission can potentially occur in the endoscopy suite, and there's been a few studies looking at that transmission risk. One of the first studies was out of Italy at the beginning of the pandemic from January to March of 2020, and they found that 4.3% of endoscopy personnel ended up testing positive. The vast majority, or 87.5% of those transmissions, occurred before the implementation of widespread safety measures such as PPE. There was a subsequent larger study of 6 centers in Europe during the first lockdown from March to May of 2020 that found that 163 endoscopists who performed procedures, out of those endoscopists, 5 or 3% became positive. So there definitely is a risk of transmission, but it appears to be fairly low. Studies examining the risk of transmission have largely been adult-based, and there hasn't been a lot of pediatric literature. And as pediatric endoscopists, we have to think of some of the unique considerations that we should be aware of. So first, children we know frequently have mild disease or are asymptomatic carriers of SARS-CoV-2 as compared with adults, so that we may not pick up the virus as readily we may not think to pre-procedurally test individuals. Additionally, up to 20% of patients we know present with only GI symptoms when they have COVID-19. And many children coming for endoscopy also just have GI symptoms. So their symptoms of COVID and the symptoms of GI disease may be confused. Additionally, as I mentioned, in pediatrics, the vast majority of procedures are performed using anesthesiologist administered deep or general sedation, and these are aerosol generating procedures, placing us at risk. And finally, we know that children undergo about 3 times more upper endoscopies as compared to lower endoscopies, and upper endoscopy itself is more of a high-risk aerosol generating procedure. So all of these factors taken together may place us as pediatric endoscopists at higher risk as compared to adult endoscopists. And the features of the virus that I've discussed really cause issue for healthcare professionals working in endoscopy, as we do have a risk of transmitting the virus. And early in the pandemic, a number of adult societies produce guidelines to provide guidance around pre and post-procedure screening, around pre-procedure testing, as well as social distancing and scheduling and PPE use. And as there was very little endoscopy guidance available for pediatrics, individuals from the Endoscopy Procedures Committee of the North American Pediatric Society for Gastroenterology, Hepatology, and Nutrition came together to formulate a position statement and offer really practical guidance to help standardize the delivery of endoscopy services for pediatric patients with the aim of minimizing COVID-19 transmission to protect staff, patients, and caregivers, as well as to optimize the use of PPE. And the APPSGHAN position paper recommends airborne contact and droplet precautions, including use of N95 masks and eye protection, namely goggles and a shield, but not glasses alone, gloves and a full-body gown. And these are regardless of risk stratification for the patient, and they should be used by all personnel in the endoscopy suite. It also was recommended that endoscopy should be performed within a negative pressure room, and these recommendations really remain in place to this day. In formulating this position statement, we reviewed many other organizations' recommendations, and most did recommend full PPE for, at minimum, upper endoscopies and as well as high-risk procedures. However, given the unique pediatric considerations which I discussed, we really felt it was pertinent that pediatric endoscopists be recommended to wear full airborne contact and droplet precaution for all procedures. And although PPE recommendations are really widespread, there's some literature to suggest that they're not being implemented as well as they could. There was a recent study from the Thai Association of GI Endoscopy that surveyed endoscopists, and while about 95% of them agreed with the PPE recommendations, they really said that they were not as potentially practical, and their ability to implement them was limited in some cases. And this was particularly in countries where there was a high prevalence of COVID-19. They had significantly more difficulty implementing PPE guidance, and they considered PPE recommendations as less practical, and they had lower agreement with them. And this study really highlights the importance of local context and in trying to implement recommendations that may differ across contexts. In terms of wearing a face shield, there was some initial legitimate concern as to whether it would affect people's ability to perform endoscopy. And I'm not aware of any pediatric studies, but there were 2 recently published adult-based studies which showed that use of the face shield during endoscopy did not impact colonoscopy quality metrics, including things like withdrawal time and adenoma detection rate, or your ability to complete a polypectomy. So overall, the quality of a procedure really doesn't seem to be affected by the PPE that we're wearing now. And in looking at aerosolization, there's been a number of small case series and studies looking at ways that we can try to decrease the aerosolized particles during endoscopy. And these are just 2 examples of the many published examples of devices that have been developed. The one on the side is a mask that goes over the person's face, and it has a small hole for the endoscope, trying to decrease the amount of droplets that are released from the oral cavity. The other one's a plexiglass box that goes over the head, again trying to contain the aerosolized particles. And while these are great ideas, none have been kind of studied on a larger scale or accepted into the mainstream endoscopy practice, but they are something to look for kind of going forward, and perhaps we may see changes in practice related to these. Another issue that arose, particularly at the start of the pandemic, was the unprecedented disruptions in medical services and the cut down or the decreased endoscopy time that was available. So related to this, as part of the APPSGHAN position statement, we had offered guidance on how we can best triage patients based on the urgency of their procedures. And this framework was really developed through consensus of the 31 members of the Endoscopy and Procedures Committee. And it wasn't meant to be prescriptive, but rather to offer guidance in how you can think about triaging procedures. And they were broken down into 3 categories. So the first category is green, and these really represent emergent procedures that should proceed. And these were defined as any endoscopic procedure for which an intervention or a diagnosis of a potentially life-threatening condition, or for a condition that, if it was left untreated, would have significant morbidity or mortality. And this includes things like life-threatening GI bleeds or emergent foreign bodies like a button battery. So these things really should proceed. The second category encompasses urgent procedures, which are defined as any endoscopic procedure for which the findings can change management significantly, or if the intervention for a stable patient, which is not imminently life-threatening, however, could lead to significant complications if delayed. And this includes things like non-life-threatening GI bleeds, or, for example, endoscopy in a patient with a high suspicion for new IBD. And in these cases, you really want to weigh the risks and benefits as to whether a procedure should go ahead or not. And finally, on the other end of the spectrum are those kind of more elective procedures that can be placed on hold. And this would include things such as reevaluation of eosinophilic esophagitis or upper endoscopy for H. pylori. And these are things that are not considered to be urgent or urgent or emergent, and you could really think about postponing. And while these were initially developed at the start of the pandemic to think about how we can prioritize procedures, I know at our center, as we're reopening, we still have a long wait list of endoscopies, and we're now using a similar triage system such as this one to prioritize patients for our available procedure slots as we work through our backlog. And as I mentioned, COVID-19 really caused unprecedented disruptions to endoscopy services and presented a huge number of challenges for the practice of pediatric endoscopy. So to examine how pediatric endoscopy practice adapted to COVID-19, we carried out 2 international studies looking at this issue, one initially in April 2020 and then one in November 2020 to see how practice had evolved as the pandemic progressed. And in the first survey, we had 145 responses from distinct institutions worldwide, and these represented 27 countries. The majority were from North America and Europe, but we did have 20% from other countries. When we broke this down by kind of the regions, we noted that most institutions, regardless of where they were located, reported a drastic decrease in elective procedures to less than about 10% of normal as they were doing prior to the pandemic. And 90% of procedures reported postponing all elective cases. Most still went ahead with their urgent and emergent procedures, but the elective things as well as advanced and therapeutic cases were decreased. And as you can see here, sedation and anesthesia practices also changed at about 40% of institutions. And most of this was related to performing endotracheal intubation for all pediatric procedures, which wasn't necessarily the case prior to the pandemic. There was also changes in PPE practices. So overall, more institutions were wearing N95 procedures for upper and lower endoscopies on low-risk patients. And then, of course, more were using those on higher risk patients who are symptomatic or who had confirmed COVID-19. And what was interesting is that the initial survey, there was a drastic shortage in PPE, and up to 40% of institutions reported reusing surgical masks, and around 70% reported reusing N95 masks for endoscopy. We then went to reevaluate changes in pediatric practice, and we redid the survey in November 2020, 7 months later. And at this time, we had 75 responses of the initial 145 institutions. And again, these were predominantly from North America and Europe, with again about 20% from other countries. And at the time of the second survey, while they were having increasing number of COVID cases, they were no longer under stay-at-home or quarantine orders, and most were in phases of reopening. And overall, as you can see from here, procedure volumes had increased at most institutions as compared to our initial survey in April, where procedures had been decreased to about 10% of normal at most institutions. And elective or urgent procedures were largely not postponed at the time of follow-up survey, as was similar in the initial survey. In looking at elective procedures, this was significantly more at the time of the follow-up survey, with 77% reporting that they were going ahead with elective procedures, whereas at the initial survey, only 10% were going ahead with elective procedures. And going back in terms of the fellow participation, we looked at whether fellows were allowed to participate in procedures, and in our initial survey, only about 20% of sites were allowing fellows to participate, but by our follow-up survey in November, around 60% of sites were allowing fellows to participate without restrictions. And in terms of PPE, 29% of institutions stated that there was changes to their PPE recommendations over time. Fewer institutions in particular were reusing PPE equipment, including surgical and N95 masks, and about 46 and 44% were still using N95s for all upper and lower endoscopies, respectively. And 11% of the respondents said that their own personal PPE practices differed from their institutional practices. In order to assess endoscopists' risk tolerance, we asked them a question modified from the American Association of Gastroenterology questionnaire, really asking about them how much risk would you assume in doing endoscopy in terms of potentially catching COVID-19. And this ranged from a risk of 1 in 200, meaning they would be willing to perform endoscopy without PPE and without pre-endoscopy testing, up to a risk of about 1 in 40,000, which is they would only perform endoscopy if they were it was less than the risk of wearing an N95 and having negative pre-endoscopy testing. And most respondents were risk averse. So about 40% wanted a low risk of transmission, so they would only accept kind of a 1 in 20,000 risk, which means that they would want to perform endoscopy with an N95 and negative pre-endoscopy testing. Whereas about 33% said they would accept a risk of about 1 in 5,000, which is equivalent to wearing a surgical mask with negative pre-endoscopy testing. And the AGA used this information from their adult survey to guide endoscopic practice. And while we have this data for pediatrics, we don't have kind of reliable data in terms of the overall prevalence rates of COVID in pediatric patients because of the high asymptomatic positivity rates. So more information is really needed in this regard before adjusting PPE recommendations for pediatric endoscopy. One of the main things that's helped us to open up endoscopy has been the availability of pre-procedure testing. I know at our site we use this quite widely as we opened up our endoscopy times. We're now not using it because our prevalence rates are so low. And within adult organizations, there's been kind of mixed recommendations regarding this. Some organizations, such as the AGA, have come out and said it's not necessary. However, I really think that you need to look at your context, as it really depends on what the local prevalence rates are in your area, what the vaccination rates are across ages, as well as what the availability of PPE is in your area. You also have to look at kind of the pros and cons of pre-procedural testing. So there are a lot of benefits in terms of reduction in patient anxiety and reassurance of healthcare workers, but there are also some harms in terms of potential delays in care, the cost of testing. It can also potentially exacerbate health disparities as access to testing can be an issue. And there's also some downstream consequences of false negative results and false positive results, such as unnecessary quarantine. So you really have to think of your local context and what works best in your context. In terms of another survey, I just wanted to point out a survey that we've done of pediatric gastroenterology division and group heads, and these are individuals who have had to respond rapidly to the pandemic to implement changes within their divisions. And we surveyed them around all areas of clinical practice, but I just wanted to highlight some of the findings with regard to endoscopy. So again, this was a web-based survey through NASPGHAN and APPSGHAN, as well as through the APPSGHAN listserv, and it was of division and group heads. And we had 165 division and group heads from 20 countries respond. And most were in North America and Europe, but we had people from all over, and we had a great variety in terms of practice setting and group size. And overall, the clinical care was affected across domains, but endoscopy was really the most affected. So 77.4% of institutions reported that there was a greater than 75% reduction in endoscopy activity during the pandemic, which was more than ambulatory and inpatient. And with regard to endoscopy care delivery, almost 100% of institutions said that there were changes in the way they were delivering endoscopy. And this was mainly with regard to postponing elective procedures or restricting the number of individuals in the endoscopy suite, or things around trainee participation or modifying staff coverage. There was also a decrease in revenue as a result of the pandemic. Estimates of losses varied widely, with about 75% reporting a more than 25% revenue loss. And top-rated endoscopy-related priorities were around reopening from a division head's perspective included triaging postponed procedures, ensuring availability of pre-procedural testing, and ability to maintain safe patient flow and space capacity. And some successful strategies that they reported within the survey were around scheduling, implementing backup coverage, and split coverage. So in terms of lessons learned that came out of the survey, one was around virtual care, but also related to endoscopy, use of patient paperless registration and virtual waiting rooms where people would wait in their cars and get called into the hospital by text message just before their endoscopy to decrease the number of people in the waiting room, and also having better processes around patient triage and flow. And I think in thinking of the pandemic, we often think of the negative things, but there are some very positive things that have emerged from the pandemic. And one I think are particularly related to endoscopy is around the emergence of less invasive procedures and minimally invasive testing. So if you take eosinophilic esophagitis as an example, two emerging things are around transnasal endoscopy is becoming very popular as a minimally invasive, a less invasive way of testing, because you don't have to sedate the patient, and also use of things like the cytosponge for potentially testing for EOE surveillance in a minimally invasive way. Another implication I think that's come out of the pandemic is around training. We did a study of around 800 GI trainees from 63 countries, and 90% of them reported a reduction in endoscopy case volumes. And there's a lot of concern around contracting COVID-19, but also concerns around can they attain competence or do they have to extend their training? And born out of this have really been modifications to the way we are training endoscopy trainees. I know at our site we're doing a lot more simulation-based training. So this is just an example of something called just-in-time simulation-based training. So we know polypectomy has been an issue with our pediatric trainees. So we're having them train on simulators and then getting them to do it in the clinical setting as a way to better prepare them. I think another thing that's also come out of the pandemic is around alternative forms of education that is really geared to fellows. And these include things such as structured conversations on Twitter related to endoscopy. So an example of this is Scoping Sundays, and also the emergence of webinars by organizations such as the World Endoscopy Organization. And these are both geared at fellows, but for example, the WEO has a series called the Telepet, which is geared to endoscopy trainers and teaching people how to teach endoscopy and how to better integrate simulation-based training into endoscopy training. And I think these are really positive things that have come out of the pandemic. So overall, the studies within pediatric endoscopy really indicate that COVID-19 has had a significant impact on pediatric endoscopy practice, with a drastic decrease in the amount of cases initially, and we're just kind of beginning to ramp that up, but are now dealing with backlogs. There's also been an economic impact of the pandemic, but really there's also been a number of lessons learned around the importance of preparation and having systems to lessen the impact of future pandemics and resurgences. And there have been a number of innovative and adaptive measures across pediatric endoscopy services worldwide, really geared at trying to minimize transmission risks to both patients and to providers while ensuring continuity of care. And guidance for future resurgence is still needed, particularly around the role of pre-procedural testing and when that should be done or not. And also, as I mentioned, the disruption to endoscopy education has really been significant, and we need to look at the uptake of things such as simulation-based education and web-based education and how we can use those best and most effectively going forward. I'd just like to thank my many collaborators who've helped with a number of the studies that I've presented today. And thank you again for the kind invitation to speak today. And I'd be happy to take any questions. Thank you.